Good afternoon, everyone. Welcome to the Coding and Medicare update for 2024. And the Broward County Medical Association is honored once again to have Jean Acevedo present this webinar. Jean has been exclusively endorsed by the Broward County Medical Association for over 20 years. And we're so happy that she's considered still one of our friends and is always helping us out. So welcome, Jean. Thank you very, very much. And would you mention something about Change Healthcare? Because now I'm...
Yeah, okay. So yeah, my office actually asked if we should send out an e-blast, and I was hesitant to, in case we upset some people who didn't need to be upset. So Change Healthcare is a very large national organization. Some of you may have them as your clearinghouse. They had a significant cyber incident that has impacted all of United Healthcare, at least one of the Medicare administrative contractors, so far as I know, not First Coast, and some individual practices, etc. So hopefully no one that's listening has found themselves without being able to submit claims to one or more payers, but it is a good reminder that I probably should be doing a HIPAA update today and reminding everybody about good cybersecurity policies. I can't tell you how many times in the course of a week I get an email that I'm like, no, that's not from Cynthia. This is some phishing with a PH, phishing email trying to get me to click on a link so that some ransomware or something, some malware can get into my system. So I can't stress enough how critical it is for us all to be cognizant of that and be careful. But if you hear something, if you do a search on the Google, Change Healthcare, I'm sure you'll come up with one or more of the entities that are being impacted. United Healthcare, I believe, was the first one, so you can tell how big that is. So hopefully, like I said, the overwhelming majority of you this afternoon, or hopefully even all of you, aren't being impacted, right? So, but if you hear rumblings, that's what that's about. So, okay. So I know it's lunchtime and I don't have the 3 hours I would like to do this. So I'm going to give you some highlights of some things and zero in on what, just from at least my perspective, is probably some of the most important things that I think everybody needs to know for 2024 when it comes to coding in the Medicare program. And yada, yada, there's me. Disclaimer, at this time of year is always important. A lot of what I'm going to talk about has been published in CPT or in the Medicare physician fee schedule, and most of it has yet to have any further explanatory documents, right? So like from the AMA, whether or not there's a CPT assistant article to further expound on something, or in the Medicare program, have they published Medicare Matters articles on some of these things? And actually, one or two of these things they actually have within the last couple of weeks. So remember, at the beginning of the year, whatever you hear, whether it's from me or someone else, may be subject to change as the powers that be realize that maybe they weren't as clear as they should have been in the beginning. So I'm going to go over the changes to CPT, and of course, it's just going to be highlights in most areas. There are some concepts, things when it comes to evaluation and management services that I will go into in a little more depth because unless you're a radiologist or a pathologist, should be or are impacting how your providers are documenting and your coding and billing their services. I will go section by section through CPT, but again, really just high-level highlights. I never know who's in my audience as far as specialty, so I don't want to bore anybody to tears. And then HCPCS, the two new codes that are, at least from my perspective, of the greatest interest because they have the potential for the greatest impact that as CMS, I think, actually intended. And CMS has also created G0136 for a social determinants of health risk assessment. And then after I go through the codes, just give you some highlights, things that you may or may not have heard yet about the Medicare changes for 2024. You know, things like where are we with telehealth for this year, et cetera. All right. CPT. And just a reminder, I don't necessarily have, and I can tell you I do not have full code descriptions. I'm not including all the parenthetical notes, etc. Where in some instances you'll see that I have allowable amounts, they are here, right here in Broward and Palm Beach County. They're locality 3 first coast service options. So we had just short of 350 total changes for this year, with 230 codes added. And, you know, for years, I've been saying if someone, especially outside of our industry, asked me, well, how many CPT codes are there? I've been saying about 7,500. Well, clearly I hadn't counted in a long time, as things were added every year, because we now have over 11,000 CPT codes. So if anybody wonders why it's so difficult and asks, is it really complex to code for medical services? There's your answer. It sure as heck is. And as the AMA stated, you see the little quote at the bottom back in September, the code set continues to grow and evolve and reflect the rapid pace of innovation in medical science and health technology. And that is reflected specifically and of course, in all the category 3 codes. So here's a breakdown, just as a point of interest. You will see that there's one new evaluation and management code, and I actually get a kick out of this code, so hopefully you'll bear with me when we get to it. Nothing in anesthesia, only 33 new codes in the whole entire surgery section, only one in radiology. Pathology and lab, I'm not going to spend any time on that with you guys, because although there were a dozen new codes, most of them, if not all of them, are in genomic sequencing and some of the more high-tech lab procedures, which I'm pretty sure we're not seeing in doctors' offices being performed. The main interest should probably be sharing that section of the book with your physicians in case these are tests that they would like to order, right? So medicine, of course, has the most because that's that catch-all section for codes. And I think most of those are in the immunization and vaccine administration section. Category 2 codes, your performance measurements, no changes there. Category 3 codes, again, 70 new codes. So this is where they're capturing all the new technology. What should be interesting to some of you is that the 23 deleted codes doesn't mean that these codes have just gone by the wayside. Well, I guess I stated that wrong. The codes have indeed gone by the wayside, but the services or procedures that they represented, for the most part, are now category 1 CPT codes and account for a lot of the added codes that you see there, right? And I'm still waiting to find the person who can really explain to me why we have these proprietary lab codes. But since I don't know and no one has volunteered, I won't be going into those, that's for sure. All right, E&M, and unless you're radiology or pathology, evaluation and management impacts your practice one way or another. So some of you may have heard me say in the past, and I believe it bears repeating, that it's insufficient to just look at the codes. So what do I mean by that? What do I do when I get my new CPT book every year? So I go to the book, I open the book, and I go to the appendix in the back that lists all the new codes. You know, they have the little red dot. the new codes, the revised codes, deleted codes, and I zero in on what are the CPT codes, depending on what number they start with, that represent services that I know we work with physicians or other healthcare providers that bill them, right? So if there's a new E&M code that starts 99, I know that, oh yeah, we need to know about evaluation management. I'm going to go to that section of the book. We do a lot with rheumatology, with orthopedics, with GI. So if I see new codes in those sections of their procedures and services, I'm going to go to those sections of the book, etc. So that's a good place to get started so that I don't find myself in June saying, oh, I didn't know there was that new code. But when I go back, say evaluation and management, I don't just go look at that code. So I told you there's one new E&M code this year. I did not start when I said, oh, one E&M, I need to go to the E&M section. I did not zero in on that code. I started from the beginning of that section. And lo and behold, there are significant changes in the evaluation and management services guidelines. There are some technical corrections. There are some clarifications of concepts. There's a whole new section on how to determine time for time-based codes. And the time as it's listed for office visits has changed from December 31st, right? So, and that's so important because it's one thing to know that, well, this code means X, because in general, CPT is a dictionary, right? Rather than words and definitions, as you'd find in Webster's dictionary, we have 5-digit medical codes and their definitions. But how to use them, right, is what's probably even more important than recognizing the code itself. So I can't imagine, unless I worked for a radiologist or pathologist, that I wouldn't look at the guidelines, introductory sections of E&M. And, excuse me, one of the areas that was significantly revised is the section there on split or shared visits. So just a reminder, we have two concepts that represent, hey, the answer to the question, hey, if my nurse practitioner or physician assistant sees the patient, what are the circumstances where I can bill that visit under me, the doctor, right? Burning question, because there's a differential in payment. So in your office setting, if you're billing place of service 11, you have incident to billing. Doctor has seen the patient already. The non-physician practitioner is seeing the patient in follow-up. Doctor's in the office suite. The non-physician practitioner doesn't address any new problems, doesn't make any treatment changes. For the Medicare program, you can bill that. If all of those circumstances are in place, you could bill that under the doctor. Okay, but what about those of you whose physicians are employed by the hospital, or when you go to the hospital and do inpatient work, or the nursing home, or a patient's home? Oops, let me take that back about the home. Facility, new provider-based office, so place of service 22, inpatient hospital, skilled nursing facility. No incident to services are allowed to be billed in those settings. Instead, we have this split or shared visits. And the concept and requirements for that, Medicare has had for years and years. In 2021, the AMA with CPT put itself in the mix. And there's been a back and forth kind of each year between the AMA and CMS on how to determine who you can bill under. This year, they both finally agreed. So this is only now for inpatient hospital, skilled nursing facility visits, and for any of you whose physicians are employed by the hospital, so it's provider-based billing, and you don't use place of service 11 for your office visits, you use place of service 22. I think I said that. So what did CPT say? And I did this copy and paste because it is a good example of what you should look for when you go to look for guideline changes. In my book, and I'm assuming it's probably the same in all of yours, in my CPT book, the new or revised descriptions, introductions, guidelines, requirements are in a pale green font. So I did a copy and paste from one of the AMA's documents. They actually did it in what's called a red line version. So what was there before, I've kept in. That's the red font with the lines through it, line through it. So it speaks to a shared or split visit and what it is, and when the physician and the non-physician practitioner may each provide a portion of the face-to-face and non-face-to-face work related to the service. Now, I did this deliberately because CPT used to say part of the related to the visit. Now they're saying service, which means that, I guess, this extends beyond evaluation and management. I'm not sure what that would be, but definitions and semantics and words in the coding world are very meaningful. And here's the one area now, though, where CPT splits with CMS, because split or shared quote unquote service is not applicable to CMS. CMS has only split or shared visits. So no, for the Medicare program, this only applies to visits. So you choose the evaluation and management service code based on one of two ways: how much time was spent preparing to see the patient, time with the patient, and time about the patient after the patient is left on the same date as the face-to-face visit. And so you can choose who to bill under when the non-physician practitioner, physician, both are involved in one or more aspect of that care. If the E&M code is being chosen based on time, whoever provided the majority, i.e. 51% of the actual minutes. Okay. Straightforward, except that most visits, especially in the hospital, the nursing home, are not billed based on time, so not as often used. The definition for how to choose who to bill under, who provided the substantive portion of the care, changed this year from last year substantially. Now it says that the physician or other qualified healthcare professional who made or approved the management plan for, one, the number and complexity of the problems addressed at the encounter, and takes responsibility for that plan with its inherent, two, risk of complications and or morbidity or mortality of patient management. And I said it that way with the one or two, because for any of you who have become pretty well versed in how to determine the level of service of an evaluation and management code now, know that for medical decision making, those are two of the three elements, right? So it has nothing any longer, even this, to do with who did the history, who did the physical exam. It's all about complexity. And if you read that, what this says is that's the person who performed it or approved this. So I actually wrote to CMS in early December, because when I read that and knowing that CMS agreed with the AMA on this, I read it and I went, wait a minute. Does that mean that the physician could in the hospital setting or in a provider-based clinic just enter into the record that she had reviewed the nurse practitioner's note and agreed with the impression or assessment and the plan? Right. So I wrote, and I'm like, that can't be. Medicare would never just allow that. So I wrote to CMS on December 4th, and last week I got a reply. First, they apologized or thanked me for my patience, since it was a good 2 months. But what they reminded me in their email was that in another rule, and I believe it was the 2021 or 2020 physician fee schedule rule, that CMS had said that physicians in a team-based care, right, that there's the nurse practitioner, there are all these people involved in the care, that the physician does not have to redocument what those folks wrote. So apparently, yes, if the doctor has documented that he or she approves the management plan for the patient, that assuming you're in a facility setting, the encounter could be billed under the physician, whoever the billing person is, according to CMS. So for the Medicare program, has to sign the note. Right? Distinction is that CPT doesn't say the place of service, right? So if you're doing a split or shared visit and you're billing a commercial payer, who, especially if they have no policy on split or shared visits, it doesn't matter the place of service. It's possible that you could use this in your office setting, et cetera. The Medicare program wants to now know, okay, are you billing us under this provider when there's been two providers involved in this encounter, whether you're billing under the non-physician practitioner or the physician? So modifier FS needs to be on the evaluation and management service code. Okay, so that was probably confusing, but for those of you who do split or shared visits, hopefully there's some clarification, and I would refer you back to the CPT codebook to read the entire section on split or shared visits. So, and then another area that was revised in CPT for evaluation and management was whether or not you can bill for more than one E&M service on the same date. And CPT and CMS have never agreed on this. And CPT has now adopted CMS's policies, which basically says that only one service is reported, on the date of service. It's probably what you've been doing, because most payers probably wouldn't have paid, regardless of what's in the code, right? The one exception in CPT does allow the reporting of two evaluation management services by the same practitioner on the same date of service. Medicare does not. So that would be, I see you in the office, I do my office note, but my plan is to admit you to the hospital. So I send you to the hospital, and then I see you again later, and I do my admission H&P. According to CPT, assuming there are two distinct services and two distinct notes, not just that your doctor has sent over his office note to be the admission note. According to CPT, you could bill both. And this is an excerpt of some of that policy from CPT. Again, if this impacts you at all, or you think it might, go read the entire section of the guidelines at your authoritative source. And that's just more of the same. One of the things that, for some of you, the clarification that the AMA did at the CPT and RBRVS symposium in November is, well, what happens when I admit the patient and the patient gets discharged on the same day? So they put in this great little table that goes over it and is really clear. I really think this has brought some clarity. And CPT in this regard did adopt CMS's policy that it's not an inpatient admission unless the patient has been for admission and discharge on the same day, unless the stay, to use a word, is 8 or more hours, right? So this is a nice little tool for you guys, for those who do admission and discharge on the same day. And then at the symposium in November, they also had, as one of their examples, a great Q&A that speaks to it that I'll share. A patient is admitted at 10 p.m. through the emergency department. I see the patient the next morning at 7 a.m. and then return at 6 p.m. to reevaluate and ultimately discharge the patient. This is more than 8 hours and on 2 calendar dates. I cannot report an initial service on the date of admission as the patient wasn't seen. I cannot report 2 codes on the date the patient was seen. What may I report? Now, this is a great little example of what happens in the real world. Per the AMA, it seems reasonable to report the appropriate code from 99234 through 36, admission and discharge on the same day, from the point of view of your services. This best reflects what was performed by you. There was an admission visit on the following morning and a discharge visit early evening. There could be claims edits that would block this as the patient was in over 2 dates, though unlikely, right? And that makes sense for them to point that out, right? The payer going, wait, this isn't the admission date. patient was admitted yesterday. How could we pay you for admission and discharge on the same day? But, as the AMA points out, probably unlikely. And then the AMA does proffer an alternative billing scenario, which would be to report the initial hospital visit code and use time, and then prolonged services if appropriate. What they fail to mention there is that you can't use prolonged services until you've reached the highest level of code, so it really should only be with 99223. But for those of you who do that, some definite changes. And then, as I mentioned, there were some time changes. For anybody going to the nursing home, 2 of the nursing home codes, both initial and subsequent, have had the time for the codes changed. So 99306, the highest level initial nursing facility assessment code was, if you were choosing the code based on time, it was until December 31st, 45 minutes. It's now 50 minutes. And the lowest level subsequent nursing home visit, 99308, went from 15 minutes to now 20 minutes. Now, of course, the time is only a factor if the physician or non-physician practitioner is choosing the code based on time. And then for your office visits, so 99202 through 15, if you think back, they had from and to times since 2021, right? So like a 99214, if you were choosing the code based on time, it was 30 to 39 minutes. And 99215 was 40 to, I think, 54 minutes, right? And they were the only E&M codes that had from and to times. Every other code, right, like the 99306 was 45 minutes. It wasn't 45 through something else. So, and I'm not quite sure why the AMA did the from and to back in 2021, but they have taken it away. But what you will find is that it now says that the time must meet or exceed. So if you were to look at the definition of, say, again, 99214 and how much time was required, it will now tell you that if you're choosing the code based on time, at least 30 minutes must be met or exceeded, right? So it has the same effect of 30 to 39, but it's now consistent throughout. Also in these guidelines, there is clarification on coding based on time and using the quote and end quote midpoint. In fact, if you bill other services that are time-based, I would suggest that you read the introduction to CPT in the CPT code book, because I believe, if I remember what it looked like, that entire section on time has been changed. So real important for time-based care that we understand that there are new descriptors for time, right? So here's an excerpt from that, because if you remember, it was really clear, or I shouldn't say clear, it was really simple before this year. If the code was time-based, other than evaluation and management, they were always, I think, pretty clear about that. How much time did you really need to have spent to be able to choose the code? So let's just say it's, 30-minute code. Well, let's do physical therapy, which was, each 15 minutes. So how much time? It was when you had passed the midpoint. So physical therapy, a unit of service would be when the therapist had spent at least 8 minutes, right? But this has changed significantly. So if you do any time-based billing for other services outside of E&M, that section of the book should be read and make sure that everybody understands it. Right? That's one of the other things. I don't know who's sitting there, hopefully having some lunch and listening to this, but make sure that the information is shared with the people that need to know. Right? So, and this is again on time, but here we go in the evaluation and management section. All right, so I had said there was one new E&M code, and when I found it, I went, oh, 99459, pelvic exam. I went, oh, wow, how interesting. So this is an add-on code to an evaluation and management service code. Interesting. And I had to do two things. One, because we'd be adding this in addition to a newer established patient office visit, an annual well woman exam, I needed to make sure that I had an understanding, okay, so what is it that the doctor needs to, or the nurse practitioner, PA, needs to document to be able to bill that? So you see the little italicized description that would give you an idea as to, okay, so this is the type of exam that would need to be documented in the patient's physical exam to bill, 99459, in addition to the basic service, the primary service. And as you can, and the first thing I did after that was to go, well, wait a minute, is Medicare going to pay for this? Sure enough, $22.87 is the allowable. So I was like, all right, cool. And then my crazy little mind went, why did they do this? Doctors haven't suddenly, whether it be GYNs, right, haven't suddenly started doing pelvic exams, especially for an OBGYN. That's kind of like an annual thing, normal, or at least, right? So I did my little research, and in the little box, on the lower right, here's the synopsis. 99459 was created to capture the additional resources during a pelvic exam, since the RVUs for evaluation and management and preventative, E&M codes didn't take, gender into consideration. I went, oh, sure. In a 99203, right? There's a physical exam, I'm sure 90% of all patients get, and only the female would have a pelvic exam, right? In the preventive medicine codes, that's their age, new patient, and age-based, whether it's male or female, same code, same reimbursement. And again, I'm doubtful that the male patients are getting a pelvic exam. So this code was added, and apparently is payable by everybody, to correct a gender-based misvalued code, right? Which first time I've ever seen that happen in all my years. All right, that's enough for E&M. Anesthesia, we're going to move on. This is the second year in a row where there are absolutely no changes. Excuse me. What I did for this section is to take, starting with orthopedics, because it's at the front of the surgery section, I combined the new codes and any significant deletions or revisions by specialty with what I was able to find in the Category 3 codes. And here's why I did that. I'm going to set the stage. So just a 2-minute refresher on those Category 3 codes. Remember why we have them. And this is a real Cliff Notes version. Okay, the AMA might shoot me if they heard that this was how I was representing it, but it's pretty straightforward. So new technology, new ways of doing things, new things to do. How do we get a code? So there's a process, understandably so, that has to be followed in submitting requests for a code to the AMA. Most totally new services or ways of doing something don't get from the very beginning a brand new Category 1 code. They get a Category 3 code. They all end in a T, and I've always called them the new technology codes. It's important that you, your doctors, actually review that section of the book each year, looking for the new Category 3 codes, because for two reasons. One, it may be surprising to some of you, but many of them are payable. The second reason is that even if they're not payable, but you go and you look at the code and the doctor goes, well, I do that, right? She should bill that, because even if not every payer is reimbursing for it today, what we want is that new technology code, that Category 3 code, to become a Category 1 code, right? To be in the main section of the book where everybody will pay for it. And the only way that's going to happen is by utilization. that physicians are actually submitting those codes on their claims. I don't know the mechanism for it, but the AMA clearly gets that data after, I'm trying to remember if it's 3 years worth of claims or 5 years worth of claims. And where there's significant, substantial usage, that's when that category 3 code might become a category 1 code, right? So it's not, they're not just, foo-foo codes out there. All right, so codes both in CPT category 1, new codes for vertebral body tethering, and 2 revised category 3 codes based on some RUC recommendations. There are 6 revised codes for metatarsal arthrodesis, for bunion correction, SI joint arthrodesis. 1 code in category 3 was deleted, and guess where you're going to find it now? You're going to find it in category 1. Insertion of a calcium-based implant in the femur has 1 new category 3 code, and that kind of sums it up for orthopedics. Cardiology always has some changes every year. Right arterial leadless pacemaker, new category 3 codes. So for your interventionalists, important that they be provided with those. In fact, probably for cardiology, and interventional cardiology, there are so many significant changes again this year that I would recommend, in addition to you having a 2024 CPT code book, and I'm assuming you all do, that you spend the extra $60 or $70, that's all it is. You can do it on Amazon and get the AMA's CPT changes and insider's view for 2024. Because that's the book that for all these new codes tells you for each one why we haven't, and then typically provides a little clinical example and a bit of a procedural example, which is helpful. Not necessarily for you and me if we're speaking as a non-clinician, but for the physicians and non-physician practitioners to know, okay, so this is the type of patient this is for, and this is the scope of what they expect to see documented, right? Because the non-clinicians on this webinar, myself included, we're not documenting in the medical record. So just in general, it's a good resource, and definitely where it's not expensive and where you have procedures that have so many, can have such an impact on reimbursement, it's worthwhile, and as long as you share it with the clinicians. Phrenic nerve stimulator system, there's, as you can see, a whole laundry list of new codes. Fractional flow reserve with CT, and intraoperative ultrasound services, remote interrogation device evaluations for cardiovascular. And I have a device, and I was actually part of an informal Medtronic study about doing these things remotely. It was very interesting, and since I like technology, I was happy to participate. So very interesting for me to see some, some changes there. For further, for the interventionalists, percutaneous coronary intervention, revisions to the guidelines, for venography, if your docs do that. Again, revisions to the guidelines. So when there's revisions to the guidelines, that should be clear, a clear message. That means that, when and how we should use these codes may have changed. Right? So again, it is so important to make sure in the areas of the CPT code book that you know your physicians, non-physician practitioners provide services, perform procedures, and you know it because you bill for these codes. It's our role, I look at it, as to go look and see, there are revised guidelines. I need to copy this page of the book and give it to Dr. Smith, right? So transcatheter pulmonary artery denervation, new Category 3 code, dual chamber leadless pacemaker, and excuse me, and parenthetical revisions to codes in that section. So as you can see, a lot of new technology codes. So please don't ignore them, right? Share them with your physicians. They are performing any of these services, regardless of the specialty as I go through. They may want to incorporate them into their documentation and billing. In the respiratory system, there were two new codes, add-on codes to an existing code, 31237. And they're all for surgical endoscopy, but it's just with what is the mechanism, right? So for 31237 that has been around, it's a surgical scope with a biopsy, polypectomy, or debridement. And now we have the new code for the otolaryngologist, 31242, which is the surgical endoscopy with destruction by radiofrequency ablation, and 31243, the surgical endoscopy with destruction by cryoablation, posterior nasal nerve, etc. Right? So that's pretty much it there. I did for this one put in some parenthetical guidelines to give you an example of why I talk about. Make sure you read the guidelines in a section, look for new parenthetical or revised parenthetical notes. Excuse me, because especially like with these two new codes, the parenthetical notes are clear that neither one of those should be billed on the same patient, same date, same claim as a sinus endoscopy or a nasopharyngoscopy, the two codes that are listed here, right? So we can't bill and get paid correctly if we don't pay attention. There are two new codes that are actually for your audiologists for diagnostic analysis, programming, and verification of an auditory osseointegrated sound processor. They're time-based codes. So if you're in an ENT practice and you have audiologists who might be performing this service and documenting and billing for it, what you should make sure that those audiologists understand is that these are time-based codes. That's atypical for services performed by audiologists. So they're not used to or in the habit of saying how much time they spent in their services. Excuse me. So making sure that they understand that you can't bill 92622 for 60 minutes until, what would you say? How much time? Well, I would refer you to the introductory section of this part of the code book and see if it speaks to it. Chances are the answer is no. Then you'd go back to the introduction of the code book where it speaks to time. Some excerpts from that I provided for you earlier. Excuse me. And it would probably tell you that you have to pass the midpoint. So the audiologist should not bill 92622 for this procedure unless he or she has spent at least 31 minutes, right? And then, of course, for the 92623, same rule would apply. And obviously, you can't bill either of these codes if time is not documented. So, and that's a new concept for audiologists. Urology had some deleted, revised, and new codes for cystourethropy with urethral dilation, neurostimulator services, tibial neurostimulator services for bladder dysfunction, and some other things. So, and again, both in Category 1 and Category 3 codes. GYN, not too much. Probably the best thing for the gynecologist is the pelvic exam. So I put it here again, since those are the clinicians who probably have the ability to appropriately add 99459 to their visit codes in the office. But there is a new ablation of uterine fibrosis codes, 58580, and parenthetical note revision for 5861. So again, what is it telling you what you should and should not know about billing that code, hyperthermic intraperitoneal chemotherapy if your docs are doing that. So not too much, but a little bit something. And then neurosurgery, again, changes, whether it be in the codes or parenthetical notes, new guidelines for both Category 1 and Category 3 codes. And I hope for all of the specialties that the managers, other staff who are listening, go back. If you haven't already done it, I'd be doing a mental happy dance to see hands if I could, for the ones that say, well, we've already given our doctors the new codes and their new descriptors, and as in this first bullet, right, the new guidelines, so that they know how to do things correctly. Right? So several for neurosurgery. Ophthalmology, under suprachoroidal injections, there's a new code, 67516. That is actually replacing the deleted new technology code 0465T. So I like this example because it helps to prove my point earlier. We're not going to get a new Category 1 code from a Category 3 code unless the AMA sees, yep, doctors are actually doing this and they're billing for it. Right? So there's a new subretinal drug delivery injection code in Category 3 0810T. Excuse me. And then, unfortunately, not a change in codes, but for the code range 65778 through 780, the RUC recommended lower work RVUs. And unfortunately, CMS agreed. So the ophthalmologists are probably seeing that they're getting paid a little bit less for those codes. Radiology, only one deleted code, the 74710. Some new technology codes. There's a new dorsal sacroiliac joint arthrodesis code, which I covered also in the orthopedic section. So some things to look for in radiology. Pathology and lab, as I mentioned, most of this is genomic sequencing, some more of the more high-tech services. So, but worthwhile looking probably for your physicians to, if any of them order any of these tests, right? The most interesting thing for me in the vaccine and immunization administration section of the medicine section is the new policy. So obviously, for those of you who've been doing this, we know that, new CPT codes come out and are effective January 1 of each calendar year. You probably noticed that over the last 3 or 4 years, we have new vaccine codes periodically. Really quick turnaround time with that with COVID. And then, of course, we've got the RSV vaccines now, et cetera. So the AMA, in response to all of that, realized that the industry obviously needed a quicker development and release of codes to represent the immunization administration and the vaccine themselves. So if you do administer vaccines, immunizations in your office, I would suggest that you go on the AMA's website. You can, whether you're a member or not, subscribe to their code updates when they release them so that you can get proactively notified when there are new codes out there. Physical and occupational therapy hasn't had any code changes for, 6, 8 years or so, when the CPT gave them new codes for their initial evaluations. But this year, there are a couple of changes. One, caregiver training services, 97550, 97552. Whole new section, caregiver training. So not only new codes, but obviously new guidelines. Very interesting for me to see through the years how many, whether it be CPT or HCPCS codes developed by CMS, how many new codes are developed and are payable for services that historically would never have been paid. So who would have paid for the therapist to train the caregiver to assist the patient at home? Who would have thought that would have happened? Well, it's happening now. Who would have thought, I'm not covering this the whole of the topic, but who would have thought 10 years ago that there'd be something called chronic care management that would allow you to package, basically, document and get paid for your interactions in the course of a calendar month with your patients outside of an office visit, right? So all of these things, our healthcare reimbursement system, my belief is that are being acknowledged as services that improve outcomes, the quality of care for patients, and overall reduce healthcare expenditures, including and maybe particularly the Medicare program. And then there's also a new code for postoperative low-level laser therapy. So there actually were changes this year. You have therapy in your practice, make sure that your therapists are aware. All right, that's it for codes, or at least CPT codes. Modifiers. There weren't any new modifiers, but based on what I've talked about, and maybe we'll be talking about in a minute, I wanted to put a couple of reinforcements. So the two new codes that I spoke to you about that are for your audiologist to do, they are on CMS's list of audiology services that can be performed without a physician order. That's a good thing. Know that the Medicare program, and probably most, if not all other payers, wants to know that, okay, we performed this test on the patient, no physician had ordered it. They want to know that, so on those codes, you need to append the AB modifier. I talked about the split or shared visits at the beginning, and the Medicare program, at least, wants you to put an FS modifier on the evaluation and management service code when you're billing it under the shared or split visit concept. And I'm going to talk a bit about telehealth and what we have in place still for 2024. And do know that when you're billing for telephone-only telehealth, that the Medicare program, at least, you'd have to check your other payers, wants modifier 93, not modifier 95. So nothing new, just some reinforcement. All right, HCPCS. So there are more new programs talking about the things that I never would have expected the Medicare program to pay for a moment ago. More new programs that I could do in this talk. Principal illness navigation, very much like chronic or principal care management, only it doesn't, I'm sorry, the person providing this management on an ongoing basis doesn't have to be clinical staff, and there's a huge component of behavioral health in it, etc. Brand new services. Social determinants of health, risk assessment, I am going to talk about that. Community health integration, if you wanted to hire a trained community health worker to help within community resources, etc. All three types of services on this slide, I never would have expected even 5 years ago would have been payable services. So not for everybody, but definitely worthwhile reading about. G2211. So if you're a radiologist or a pathologist, go take a break. If you're most anybody else, this is a gift from the federal government. So some of you may remember in 2020 for 2021, CMS had in their fee schedule rule stated that they wanted to further reimburse physicians who were not proceduralists, not surgeons, I guess, for the additional work that nothing really reimburses them for that's involved when they take care of patients in the office with an add-on code. And they had proposed paying something in it for this G code starting 2021. The specialists who are procedurally oriented, understandably, went to Congress and said, wait a minute, our payment system in Medicare is budget neutral. If CMS starts paying our colleagues who don't have their surgeries, et cetera, more for office visits with this add-on code than we get paid, that money has to come out somewhere. It's a budget neutral system. And I'm sure that means that it'll come out of my pocket. So Congress that year, in one of their year-end laws, did indeed instruct CMS told them that they could not implement this add-on code any earlier than January 1, 2024. Well, January 1, 2024 is here. So G2211 is a payable code in Broward County. The allowable is $16.54. What is its definition? Visit complexity inherent to evaluation and management associated with medical care services that serve as the continuing focal point for all medical healthcare services. Okay, that speaks to primary care. And or with medical care services that are part of ongoing care related to a patient's single serious condition or a complex condition. Okay, so here are the other folks. So here's the rheumatologist, the endocrinologist, the gastroenterologist, and excuse me, even some otolaryngologists and other specialists when they are following a patient for a chronic condition. Right? So what more do you need to know? I'm not going to read you all the information on these slides. The information that I'm showing you on this code comes directly from CMS. I don't think I have an original word in here because it's too new and I don't want to be guilty of misinterpreting it. But as you read this, you start to understand there are two things that CMS looks at as to when should you, in addition to an office visit, bill G2211. Another line, add additional code. It's based on the work, the physician, non-physician practitioner, the physician. It's the work building an important relationship between the practitioner and the patient for primary and longitudinal care. Are you taking care of this problem ongoing that has been previously unrecognized and unaccounted for during evaluation management visits? That's CMS's intent. It's the ongoing physician relationship and longitudinal care. So rheumatoid arthritis, diabetes, hypertension, all of those conditions, specialist or primary care. Another excerpt from CMS to make it clear that this is not just for primary care. This code is not restricted to medical professionals based on specialties. Instead, it should be used by medical professionals regardless of specialty with office other outpatient E&M visits of any level other than those reported with the 25 modifier. So if you're seeing a patient in the office, performing a procedure that's also going to get billed, so your staff are putting modifier 25 on your office visit code, do not include G2211 on your claim. For the care that serves as the continuing focal point for all needed healthcare services and or with medical care services that are part of ongoing care related to a patient's single serious condition or a complex condition. And you've got more information that I would encourage you to read, right, so that you get an understanding. And the change request from CMS says, to reiterate, the most important information used to determine whether the add-on code could be billed is the relationship between the practitioner and the patient. So I was doing a baseline chart review 2 weeks ago on a new physician in town for a practice I work with. And at the end of his new patient note, he had RTC PRN, so return to clinic as needed. No G2211. There is no relationship he's building. There is no ongoing, i.e. longitudinal care, right? Nice for the patient, but doesn't meet the requirements or definition of G2211. If the practitioner is the focal point for all needed services, such as primary care practitioner, the HCPCS G2211 add-on code could be billed. No frequency limitations. So doctor, you're my primary care physician? You're billing, you're it, right? You're my primary care physician. There are no frequency limitations. Other than when I see you for my annual wellness visit, because that's not an office or other outpatient code. Every time you do bill for an office visit code, chances are 90% of the time or more, G2211 would be appropriate. If the practitioner is part of ongoing care for a single serious and complex condition, and CMS gives you the example of sickle cell disease, then the add-on code could be billed. So it's not only for primary care. The intent of this code is to capture the inherent complexity of the visit that is derived from the longitudinal nature, so this ongoing, of the practitioner and patient relationship. Two different buzz phrases, longitudinal care and physician-patient relationship. That's what the basis is for all of this. When would you not also report G2211 with an office visit code? If modifier 25 is on the office visit code, and I've excerpted this from the change request as to what kind of conditions do they CMS consider that would not meet this, ongoing complex care, etc. A mole removal, treatment of a simple virus, counseling related to seasonal allergies. The first visit for a patient just got GERD. Treatment of a fracture, right? That last one should be obvious. Hopefully the fracture is going to heal well. There'll be no ongoing care, right? So, excuse me. So it's pretty ubiquitous when it comes to the primary care, internal medicine, and subspecialties. Okay. I'm going to go quickly through this one to make sure that you guys can get back to work. GO136 is a risk assessment for social determinants of health. It's defined as administration of a standardized evidence-based social determinants of health risk assessment, 5 to 15 minutes, not more than every 6 months. So patient is in the office, and as you can see, Medicare allowable is just short of $19. Patient's in the office or being scheduled for maybe their annual wellness visit, and there's a problem for them with transportation. I really can't come before 4. I work on an hourly basis. I don't get any paid time off, right? So, and transportation is rough. The patient has expressed a situation that could support that they have some social determinants of health social determinants of health are impacting their care, whether before they come in or at the next encounter. Risk assessment could be provided to the patient at an E&M visit, the annual wellness visit, most behavioral health visits. It isn't a questionnaire that you would develop yourself. It needs to be a standardized form. There's about a half a dozen links in this presentation if you're interested to do that. Can only be billed with these visits or these encounter codes, I should say. And you are not expected to, let's just say that there is a transportation risk that comes up that the patient can't get to the office, or I'll use the one that CMS uses. Patient's living situation doesn't permit reliable access to electricity, and the patient is on insulin, so it's not necessarily reliable for refrigeration. So that alone might help the practitioner realize that maybe another type of insulin that could remain stable at room temperature, or maybe some oral medication regime needs to be ordered instead. So just do something. For those of you who are in a specialty where probably one of the most common impacts of social determinants of health is the financial burden of some medications, because the patient doesn't have medication insurance, the prescription drug plan doesn't cover a sufficient amount of a medication. And that's also an impact of social determinants of health on the patient's treatment. What could you do about that? Just refer them to the pharmaceutical company's copay assistance program, something like that. All right, so I'm going to skip through those. You've got some, some URLs, as I said, for accessing and assessment that you could use. When this is reported on your claim, what codes would you use? CMS is encouraging the Z codes that represent social determinants of health. I would say that's what you need to do. I don't know why they're being so polite. What else would support G0136, which is a social determinants of health risk assessment, other than a social determinants of health CPT code? Right? So you can read the rest, and here are, again, bunch of different areas, a couple of them with the American Academy of Family Practice for the tools you might want to use. Okay. Fee schedule. Well, by now we already know that the conversion factor went down. That doesn't mean your doctor reimbursement went down. It depends on the mix of services that you have. What CPT codes do you bill? And for the doctors who can bill G2211, chances are you're at least neutral, if not up a bit this year. So I'm going to go with, for any mental health providers that we have, there's really been an expansion in this area, more than I could ever do on this talk today. In fact, there are 2 new quote-unquote provider types that can register with the Medicare program: marriage and family therapists and mental health counselors, including in the latter category, counselors on addiction or counseling and drug and alcohol counseling, as long as they meet the requirements of a mental health counselor. So these folks can be Medicare providers now, right? And codes that they can bill for, et cetera. So a lot of push by CMS to enhance our mental health offerings. So you can read that. Okay, telehealth. Pretty much everything you know is remaining the same through the end of 2024. A couple of things that I want to point out is that there is a list of quote-unquote approved CPT codes that can be billed as telehealth. And on that list, there's a column that they have a yes, where it applies, to those CPT codes that can be provided and billed as telehealth audio only, so on the phone. To give an example of the type of codes that might be there, this new G0136, the social determinants of health risk assessment, is indeed on the list of approved telehealth services, right? So I'm not giving you the list, but if you go to cms.gov and type in Medicare telehealth services list, right, it'll come up. It's a big Excel file and it changes periodically, which is why I don't like to provide it, because next week it might be obsolete. Just go to the Google. When you are providing telehealth, we had been told throughout the pandemic to, assuming that the patient would have come to your office, if it was a face-to-face visit, you should always bill place of service for office, so 11 or 22. This year, when the patient is at home and you're providing telehealth, assuming from your office, the place of service needs to be 10. Telehealth provided in patient's home. CMS had to change the claims adjudication process for claims bill of place of service 10 from facility to non-facility, because the reason you weren't able to do that before when the patient was at home is that you would have been paid a lower rate. That's been fixed. So it's perfectly fine, and it's actually accurate. If the patient is at home, where most of your patients are when you're providing telehealth, place of service on the claim should be 10. The address, the location, would still be the office address where the doctor or other practitioner is. For those of you who are using any telehealth in the facility setting, in the hospital, the nursing home, the limitations that existed before the pandemic have continued to be lifted through the end of 2024. It used to be, for example, that only 1 out of every 3 inpatient subsequent hospital visits could be billed via telehealth. That was, excuse me, that limitation was removed during the public health emergency and is still removed through the end of 2024. For those of you, excuse me, who are providing services incident to the physician, so maybe the patients are coming in, you've got a patient coming in today for a B12 shot that the nurse is giving, and the doctor isn't in the office to provide the direct supervision required for incident to billing. If that doctor is available to that staff member via audio video telehealth, not just telephone, make that perfectly clear, you can count the availability of the supervising physician available through real-time audio and video interactive telecommunication as meeting the direct supervision requirement. Don't just think that you could have a doctor not be in the office and say, well, if we needed him. No. Make sure the nurse knows exactly how to get a hold of the doctor. You better have it documented. Heaven forbid something even goes wrong with the patient. But this is something that was put into place at the beginning of the pandemic and has been extended through the end of 2024, which I find real interesting. Some of you may have heard that when your doctors were doing telehealth from their home, they had to add their home address as a practice address to the Medicare program. CMS heard the roar from physicians going, whoa, wait a minute. My personal home address is going to be public. I'm concerned for my privacy, some for safety, etc. So CMS rescinded that requirement. You no longer have to add your physician's home addresses to your practice locations. Thank goodness. Let's see what I didn't mention. I don't know, again, my specialties I have listening. So for anybody who's doing mental health, there was a requirement that you had to have an in-person encounter with the patient, at least within the last 6 months, to do any mental health telehealth. That requirement is not in effect. No originating site restrictions, i.e. the patient can be at home, your doctor can be at home. The frequency limitations being suspended as well, I mentioned. Audio only provisions of services for things on the telehealth services list. Everything that was covered since December of 22 continues. Do know that if you're providing a telephone E&M visit, you shouldn't be billing normal office visits. You shouldn't bill a 99214 for a telephone only encounter. There are telephone-only encounters, 99441, 2, and 3. They're time-based, so time must be documented. That's what should be used. Physicians can provide direct supervision of clinical staff through real-time audio-video telehealth, as I mentioned. And yes, practice location for the doctors doing telehealth at home. They don't have to give their home address and put it out there for the Medicare program. Let's see. Yeah, I already talked about these 2 codes being able to be performed by an audiologist without a physician order. So that was done. Medicare revalidation is in process. So remember, that was something that we would get noticed from First Coast Service Options here in Florida every 5 years. Time to revalidate the practice, time to revalidate these 7 practitioners, etc. It's up and running again. If you're adding a new Medicare provider to your group, we had this simple little form, an 855R, R for reassignment, that would be used. That form was eliminated actually back in November last year. You still have to have the provider reassign their benefits, but now that is done via the 855I. Whether you do it through PACOS or a hard copy form. I mentioned the 2 new provider types. I talked about this. If anybody's doing chronic pain management, there is a whole new bundle payment system if you're interested. nicely, MIPS hasn't really changed, so I didn't have to stick stuff in here. All right. So there are significant changes to CPT this year, and there are guidelines for that will impact many of you. I hope some of that was old news to some of you. Please do check if there are Category 3 codes that your clinician should be using. Make sure to communicate that with your docs. And I know I didn't talk about ICD-10 because we're like 5 months into the current year's worth of diagnosis codes. But I do want to emphasize, because I see it having increased importance all the time, that make sure that your doctors are not using a bunch of unspecified codes, that they're actually coding why they actually saw the patient today. So one doctor in Miami that we work with sent me a letter from one of the managed care plans that she got that said that they are seeing too many level 4 and level 5 office visit codes. And they're implementing a program where they're going to be checking the ICD-10 codes on the claim to see if they actually support that level of E&M code. Obviously, they're not going to release that list or anything. And it's like, so just make sure your diagnosis codes are being reported completely and accurately. And now, of course, G2211, I would imagine that if CMS 2 years from now wants to audit to see if that add-on code has been reported correctly, they would probably zero in on a doctor who had a new patient claim for a URI and nothing after that, right? So probably nothing to do with longitudinal care and a physician-patient relationship, right? So diagnosis codes, my instincts tell me, are going to be what they'll look at when they start. I wouldn't worry about it if you're primary care, et cetera. All right. Done. I am done.
Thank you. I have a question.
Sure.
On Medicare revalidation, are you sending something out about that? Because I haven't heard anything at all from the doctors. I did hear back when they were doing Medicaid and having to get fingerprinted again and all of that. But and did you say there's a form they have to fill out? Is Medicare telling them that? So okay.
The revalidations, I hadn't sent anything out because it's just restarting of something we should all have been used to, right? Just to remind people that it is starting. So if they get a revalidation notice, they need to pay attention to the time that they have to respond so that they don't find themselves with a practice or a provider who no longer has a Medicare number. And then there isn't a new form, but as folks add a new physician, a new nurse practitioner, physician assistant, physical therapist, audiologist to their practice, they've been using, for most of those, the Form 855R, especially if that individual had a Medicare number already, to allow them to bill and be paid for that individual services. And it's just that form doesn't exist. They now have to use another form that's existed forever, the 855I.
Okay. All right. Thank you, Jean, very much. Does anyone else have any questions?
I don't see anything in the, wait, there is something here. Let's see. Now, this is something that I can, bear with me, guys. Oh, I actually was able to open this. All right, here are 2 questions I see. I have a virtual/telehealth visit question. Can the visits be done if the patient is outside of the United States and outside of the state of Florida? Wow. Okay, so outside of the state of Florida depends on the laws in the state where the patient is, Angela. So if I'm in New Jersey, right, and you and I are having a telehealth visit today, what you have to worry about is, does the New Jersey laws allow you, someone probably without a New Jersey medical license, to perform telehealth, right? And then for a patient outside of the United States, I believe the answer to that from a Medicare perspective is no. So I know I'm hoping to go on a vacation out of the United States in the spring. And I was reminded that I need to get, health insurance to cover things. But wait, that would be, hmm. Well, telehealth outside the US, United States patient, American citizen, I'm thinking out loud, which is a very messy process. So bear with me. Outside of the state, another state, you need to check that state's licensure, scope of practice laws for the doctor, nurse practitioner, etc. Outside of the country, assuming, let's just say that this isn't otherwise Florida resident, it's actually liable to be okay. Do document where the patient was. All right. Jennifer asks, can you give an example of a psychiatrist using G2211? Okay. So assuming that the psychiatrist is billing an office visit today, and maybe she is because of the medication management, etc. And the patient is being seen maybe just for medication management for their depression drugs. Right? So depression is definitely an ongoing kind of complex condition. If the encounter appropriately meets the requirements for an evaluation management service versus one of the psychotherapy codes, etc., then yes, right. It's all about only with an office visit code, so only with 99202 through 99215, and for a problem, a condition where here's the words that CMS's one of their representatives used on an open door forum call last month. It can't be a one-off, right? So if it's a one-off, no, don't even try using G2211. So they intend to publish, at least that's what the same gentleman said that day, a further list of FAQs, etc. So more to come when we get that type of thing, because that code has such far-reaching implications for most office practicing physicians, right? I'm assuming you're on Cynthia's list because you got the notice of this webinar today. That would be the type of thing we'd send out to her for further distribution. So, all right, so that was it. So thank you guys. It's almost the end of the week, so I hope everybody's looking forward to a beautiful weekend. Cynthia, any final words?
No, thank you so very, very much. We look forward to hearing from you again, as always. And does everyone know that because BCMA does endorse Acevedo Consulting, that you can send in 5 questions per year. And if you have any questions and your doctor is a BCMA member, you can send them to me, or we'll have a form or something. But I just want to tell everybody that you don't have to call our office. You just send it via email, and we can send it on to Jean or one of her team members. Okay? Thank you, and have a great weekend. When I went out,
thanks, Cynthia.
Yeah, it was 80 degrees. Yes, go ahead. Somebody have a question?
No, I think that was it.
Okay, all right. Thank
you. Bye, everyone.
Have a wonderful day. Thank you, Jean. Hope to see you soon.
Yep.
Yep, yep.